and thanks to everyone for joining this morning. I'll just start by giving you a brief introduction to myself and then go into talking about the Community Outreach and Engagement Program at the Cancer Center. So I'm on the faculty in the Department of Pediatrics. I joined the faculty in 2008. I'm trained as a molecular epidemiologist, and my research mainly focuses on pediatric cancer, also on myelodysplastic syndromes and acute myeloid leukemia in adults. And then I also am one of the investigators on the new 10,000 Families, which is a family-based cohort study that we're working on starting with support from the Cancer Center. So back in April, I took over the role of Associate Director for Community Outreach and Engagement, and that's going to be the focus of my talk today. So I'm going to start by giving you just a brief overview of what the Community Outreach and Engagement Program does at the Cancer Center. And I'll also talk about some new guidelines and why this is important for all of us to think about outreach and engagement, regardless of what program we're working on in the Cancer Center. I'm then going to give you some results from an analysis of the catchment area that I've been working on since I started in this role. I then will spend some time talking about the results of a catchment survey that was conducted by Deanne Lazovich and some of her colleagues. And then finally, I'm just going to spend a minute briefly introducing the new Community Outreach and Engagement Seminar series that will be starting at this time during the Cancer Center seminar. So before I start, I just wanted to give you a brief introduction to the Community Outreach and Engagement team. I've already introduced myself. We also have Kiara Ellis, who's the Senior Manager for Community Education and Engagement. So in her role in her office, she supports community outreach and engagement and also the Cancer Center's education program, which also does a considerable amount of outreach into the community and is led by Dr. Chris Pinnell. Working with Kiara, she has a team including 2 community engagement coordinators, Abdi Ahmed and Sylvette Lopez Ruth. They do a lot of the boots on the ground work going out into the community to spread the word about what the work the Cancer Center is doing. Patty Beckman is an oncology patient access nurse who works with patients who have questions about care. And then Lissa Martinez-Hubner is the events and program coordinator who does a variety of things, setting up seminars and also supporting the work that the office does. And then we also have 2 students who are working with Lissa in the office as well. In addition to the team at the Cancer Center, we also have an internal advisory board comprised of members within the Cancer Center. Just a heads up, we'd like to include someone from every program at the Cancer Center in this internal advisory board to make sure our community outreach and engagement activities are coordinated throughout the Cancer Center. So if you're working in one of the programs where we don't have someone and you're interested, we'd love to have you join, and we'll be reaching out to the different programs to identify members who'd be interested in this role. And then we also have a community impact board who serves the role of helping to advise us and help us reach out into different groups within the community. So I just wanted to give you a brief overview of some of the work that's done by the Community Outreach and Engagement Group. One of the very important activities is developing partners within the community. I mentioned this is also something our Community Impact Board helps us with. We also have the role of trying to understand the catchment area, the cancer burden, whether that's incidence rates that may be higher in Minnesota compared with other areas of the country, or different populations that have a higher burden or higher risk factor profile. We also work to provide tailored cancer education to different community groups to help them understand risks for cancer and also find ways to reduce risk and get good treatment. We have community-based participatory research pilot grants that will be funded on an annual basis in the summer and also throughout the school academic year. There are internship opportunities for students who are underrepresented in cancer research with the goal of trying to diversify the cancer workforce at the Cancer Center. And then finally, members of the group represent the Cancer Center in statewide cancer coalitions. And on the right, I'm showing you some pictures of some of the outreach activities that the group has conducted in the community. And obviously these are all held pre-COVID. We've had to pivot a lot of the work to online during the last 6 months. So one of the reasons why community outreach and engagement is so important to everyone at the Cancer Center is that the National Cancer Institute has put out some new guidelines for Cancer Center support grants, which influence the amount of funding that we get for the Cancer Center. And under these new guidelines, community outreach and engagement is a big focus under these new guidelines. So I just thought I'd give you an overview of what the guidelines are for community outreach and engagement. The first is that we need to consider the needs of our catchment area in the research across all programs. So this includes basic science, clinical research, and population science. We also need to be obtaining input from community members and organizations in our catchment area to figure out if there are issues of particular relevance that they would like us to focus on. And the ultimate goal for the program is to try to reduce the burden of cancer in the catchment area. So there are a number of things that we've been working on in the COE office to try to address these guidelines. And I'm going to share a few of them with you today, but I thought I'd give you a longer list of what we're working on. The first is a catchment analysis to try to understand what the cancer burden is in the catchment area for our Cancer Center. We also are putting in place a needs assessment in partnership with mHealth Fairview to try to understand if there are needs that aren't being met within the community. We've been doing outreach to programs and translational working groups within the Cancer Center. Chris Pinnell had initially started this when these guidelines were first released. And now if your program would like to have someone come and talk, I'm more than happy to talk about the catchment area with your program. We also have been discussing and trying to enhance the role and the composition of the Community Impact Board and the Internal Advisory Board. I already mentioned that we're interested in having members from every program in the Cancer Center participate in the Internal Advisory Board. We're going to be starting a new community outreach and engagement focused seminar series to try to disseminate information and enhance collaboration. We have a variety of outreach activities, which I already briefly described to you. We've been working on a strategic plan to make sure all of our activities are aligned with our goals. And then we're also working on outreach and engagement with other university entities who are working in this same area. And then finally, we had a catchment survey that was conducted by Deanne Lazovich through a supplement to the Cancer Center support grant, which I'll be talking about. And the things highlighted in bold here are things I'll be covering in the seminar today. So before I spend time telling you about the catchment area, I first thought I should define what I mean by catchment area when I'm talking about it. So according to the National Cancer Institute, a Cancer Center's catchment area is a self-defined geographic area that the center serves or intends to serve in the research it conducts, the communities it engages, and the outreach it performs. And it's really up to cancer centers to decide for themselves what their catchment area would be. So for the Masonic Cancer Center, our catchment area includes the entire state of Minnesota. So in the next slides, I'm going to talk about a catchment analysis that I've been working on since I took on this role. And what this involves is trying to understand unique features of our area that we should be focusing our work on. So I've started by looking at demographic features within the state of Minnesota to try to identify if there are any notable populations or areas that we might be uniquely positioned to address. I've also done a number of cancer incidence and mortality comparisons, first comparing cancer incidence and mortality in Minnesota compared to the United States as a whole to determine if we have higher risk of certain cancers. I also looked at some behavioral risk factors using data from the Behavioral Risk Factors Surveillance Survey. And then finally, I'll briefly touch on some relevant environmental exposures. And then finally, I'll end this section by talking about some priorities that were identified through this analysis. So overall, Minnesota has a population of just over 5.6 million individuals. If we look at the breakdown by race and ethnicity within the state overall, we see that the majority of the population is non-Hispanic white, as highlighted by the orange part of the pie graph here. And then we also have a smaller number of individuals of other racial and ethnic groups who also make up an important part of the catchment area. The population is equally divided between males and females. And we also, when we look at the age distribution, we find that we have most of the population in the adult range. We do have about 16% of the population over age 65, and these individuals would be at highest risk of developing cancer. If we look at notable populations within our catchment area, we have several immigrant populations of interest. Overall, immigrants in total make up about 8% of the Minnesota population. And I'm just highlighting two of the groups that are really unique to Minnesota. Minnesota has the largest population of Somali immigrants in the United States, and the second largest population of Hmong immigrants in the United States. American Indians and Alaskan Natives make up about 1% of the Minnesota population, and the Phillips neighborhood in Minneapolis has the third largest urban American Indian population in the United States. And then finally, Minnesota also has a large rural population. 23% of the Minnesota population lives in rural areas, and this is compared to the national average of 15%. If we look at cancer statistics in Minnesota compared to the United States overall, we see that Minnesota has a slightly higher incidence rate at 467 per 100,000 people compared with the US overall, which is 448 per 100,000, but slightly lower cancer mortality when we compare to the United States overall. And in the figure on the right side of the slide shows trends in cancer incidence. So if we look overall at all cancer sites, this is an average annual percent change. So looking over the past 5 years, how the rates have been changing. And anything shown on the graph with the hashtag is statistically significantly different from 0. So if we look overall at all cancers combined, the rate of cancer in Minnesota has been declining slightly over the past 5 years. And we see a number of cancers that have had significant declines in the past 5 years. In contrast, at the bottom part of the graph, we also see a number of cancers that have had significant increases over the past 5 years, most notably melanoma, liver cancer, and brain tumors. If we compare cancer incidence for specific cancers in Minnesota compared to the United States population overall, we don't see a lot of huge differences in incidence rates, but we do see a number of cancers in both males and females that are higher than what we see in the United States overall. So here I'm showing you the incidence rate per 100,000 and specific cancers on the bar graphs. Minnesota is colored in red and the United States is colored in orange. So we see that in males, Minnesota has higher rates of prostate cancer, non-Hodgkin lymphoma, melanoma, and also leukemias when we look at all leukemias combined in adults. In females, we also see higher rates of non-Hodgkin lymphoma, melanoma, leukemias, and then also uterine and breast cancers. If we look at cancers with higher mortality in Minnesota compared to the United States, again, we don't see any dramatic differences, but we do have a number of cancers with significantly higher mortality rates in Minnesota compared to the US overall. And these again include non-Hodgkin lymphoma and leukemias in men, and then kidney and brain cancers in men. In women, we see higher mortality rates for non-Hodgkin lymphoma, esophageal cancer, and uterine cancer. After comparing cancer rates overall between Minnesota and the United States, I also looked at disparities in cancer incidence within the Minnesota population. And these are data that came from the Minnesota Cancer Reporting System, or state cancer registry, over the past 10 years. So here I'm showing you cancer incidence in Minnesota in males across different racial and ethnic groups. These are the categories that are typically used by the cancer registry to classify, so we aren't able to break the groups down into smaller groups, which may be of more interest. But you'll see that we do have some incidence disparities in Minnesota, most notably within the American Indian Alaskan Native population, which is shown here in the green bar, which has a much higher rate of cancer compared to males and other groups. And in contrast to that, we see a much lower rate of cancer in the Asian Pacific Islander population. If we look at specific cancers within males, we also see some disparities that are driving these overall differences. So here on the left side of the graph, we see colorectal cancer. We see a much higher incidence rate in the American Indian, Alaska Native population. We again see much higher rates of kidney cancer in this population and also lung cancer. If we look at liver cancer incidence, we see that all populations have much higher rates compared to non-Hispanic white, which is shown here in the orange bar. And then in pancreatic and cancer, we see some much smaller differences, and in prostate cancer, we see a much higher incidence rate within the Black or African American population. If we look for disparities in females by specific cancer, we again see this higher incidence rate of colorectal cancer, kidney cancer, and lung cancer within the American Indian population. And again, some disparities with liver cancer in all populations compared to non-Hispanic white. And similarly, some differences in the incidence of uterine cancer and pancreatic cancer. These differences also carry over to cancer mortality, where we see in both males and females, we have a much higher cancer mortality rate in the American Indian population. And when we look at specific cancer mortality differences in males, we see that the higher incidence in colon cancer and lung cancer also carry over into mortality rates. We see higher liver cancer mortality in all groups compared to non-Hispanic whites, and higher rates of pancreatic and prostate cancer mortality in the Black population. And when we look in females, we see differences only for 3 cancers, again, colon cancer and lung cancer in the American Indian population, and a small increased mortality for pancreatic cancer. So I mentioned the immigrant populations, which are also of interest to look at cancer incidence and mortality. And unfortunately, we don't have incidence data or mortality rate data readily available for Somali immigrants, although this is something that I'm working on in partnership with the Cancer Registry to try to obtain these data. So hopefully I'll be able to update you on those numbers in the future. But we do have some information on cancer in the Hmong population in Minnesota. These data are from a recent publication conducted by several Cancer Center members, including Logan Spector and Anna Prisment. And they looked at rates of cancer in the Hmong population in Minnesota and found that overall this population has lower rates of cancer than the Minnesota population. However, they do have higher rates of infection-related cancers. So nasopharyngeal, stomach cancer, liver cancer, and cervical cancer. So this is also something important to consider within our catchment area. So I also mentioned that we have a much larger rural population in Minnesota compared to the US overall. And there are several reasons why this might translate to an increased cancer burden in this population, because we see a number of differences within the rural population. So overall, individuals who live in rural areas tend to be older and on average are twice as likely to be over age 80 years, which is where we see a very high cancer burden. Rural Minnesotans tend to have lower incomes, with a large number living in areas of concentrated poverty. They also often don't have access to health care locally and must travel farther, and are more likely to have public health insurance. We also see some differences in the racial and ethnic distribution in the rural versus urban population. So here I'm showing you the breakdown depending on population. So if we look overall in the metro area, we tend to have a more diverse population, with larger non-white populations. And in the smaller towns, individuals tend on average to be more likely to be white. But the exception to that would be in the American Indian population, where we see a much larger percentage of the population living in small towns and rural areas. And this is important to keep in mind given the cancer disparities that I've just described to you. So I also was able to do some comparisons of cancer incidence or mortality rates in the rural versus urban population using some data from the State Cancer Registry. So here I'm showing you cancers that had different incidence rates in rural versus urban population. So again, I'm showing you incidence rates per 100,000 population. With here we have the rural population colored in red, and the urban population in orange. So we can see that we have several cancers in males where we have higher cancer rates in the rural population. These would include kidney cancer, colorectal cancer, and lung cancer. And in contrast to that, we see higher rates of non-Hodgkin lymphoma and melanoma in the urban population. When we look at females, we had a larger number of cancers with statistically significant differences, although I will point out that most of these differences are really quite small. But again, we see higher rates of colorectal cancer in the rural population, also thyroid cancer and kidney cancer, and then a number of other cancers with higher incidence rates within the urban population. And I would just like to point out for colorectal cancer, this has been a known disparity in incidence rates for many years. We've seen a persistent higher rate of colorectal cancer in the rural population. And even as rates fall in the overall population, they've remained higher in the rural population compared to the urban population. If we look at mortality differences in rural versus urban populations, we see that the higher incidence rates of colorectal cancer in the rural population also correlate with higher mortality in this population. And then for males, we see higher rates of kidney cancer, prostate cancer, and lung cancer also in the rural population. Whereas with lung cancer in the females, it's actually flipped with higher mortality in the urban population. So when we look at these differences, it's great, they tell us areas we should focus on, but looking at incidence and mortality data don't really explain why we're seeing these differences. So we were also interested in looking at cancer risk factors and screening behaviors to see if this could help explain some of the differences we're observing in incidence and mortality. So since we see differences in colorectal cancer incidence and mortality, both across racial and ethnic group and also by geography, I started by looking into colorectal cancer screening rates in Minnesota. So using data for the state overall from the Behavioral Risk Factor Surveillance System, we see that about 73% of Minnesotans in the age range who should have colorectal screening are up to date with this screening. And this is ranked ninth in the nation. So overall, it looks like Minnesota is doing great in terms of colorectal cancer screening. However, if we look by racial and ethnic group, again in the BRFSS data, we see that there are some very notable disparities in who's getting cancer screening. So we see in the non-Hispanic white population, we have high rates, but in all other groups, we have much lower rates of screening, with rates at 50% or below for several populations. I also was able to obtain some data from Minnesota Community Measurement, which is a group of health systems who track data from medical records to determine who's accessing care. They also have some information on colorectal cancer screening rates in Minnesota. And they report out screening on preferred language spoken in the home. So we're able to get at rates in some of the immigrant populations in Minnesota. And you can see here again, non-English speaking individuals as a whole tend to have lower screening rates than other populations. I also was able to find some data from the Behavioral Risk Factor Surveillance System looking at screening rates by geography. So here, this is mapped out screening rates by county with the caution that some of the numbers in some of the more rural counties may be small and may not be as reliable. But here we're seeing that darker color coding indicates lower screening rates and the lighter green color indicates higher screening rates. So we do see some notable differences by geography in colon cancer screening rates, with particularly low rates up in northern Minnesota and also in central Minnesota. I also looked at breast and cervical cancer screening rates. So if we look at rates of mammography, overall Minnesota has about 70% of the population have been screened, which ranks 16th in the United States compared to other states with BRFSS data. But if we look again by race and ethnicity, we do see that we have some differences in the prevalence, with particularly notable lower rates in the Asian population. Similar for cervical cancer screening, Minnesota overall does quite well and is ranked 15th in the nation for screening, with about 87% having had a Pap test or HPV test. But again, we see some differences by racial and ethnic group, suggesting that we have some work to do to address these disparities. If we look at smoking rates, which is one of a strong risk factor for particularly lung cancer, but other cancers as well. If we look at current smoking rates at age 18, about 16% of the adult population smokes, which is in the bottom half when we compare to other states in the US. And again, we see some very notable disparities, with the American Indian population having close to 50% of the adult population reporting being current smokers. And again, looking geographically at prevalence of smoking rates, we also see some differences by county. So here the dark red shows higher smoking rates and yellow shows lower. And we see again across northern Minnesota much higher rates, and also some more concentration in more rural areas. If we look at obesity prevalence in the adult population, we see that Minnesota has about 30% of the population is obese, which again ranks in the bottom half compared to the rest of the US. And if we look, we again see some disparities by racial and ethnic group. We also see some differences in the prevalence if we look by county here, again with darker purple showing higher rates. Again, seeing that in rural areas, we may tend to have higher obesity prevalence. I also just wanted to spend a minute talking about some environmental exposures that may be relevant in our catchment area. I do only have one slide devoted to this, but that's not really a reflection on the importance of this. I think that exposures are really important and we need to consider these, and also are a strength in the Cancer Center. So one exposure that's likely to be highly relevant, and especially as a concern to the community, is PFAS, which is a chemical used in flame retardants and nonstick cookware. This really hasn't clearly been associated with cancer, but there is some more evidence coming out, including a paper that was just published yesterday, showing that PFOA, which is one of the components of PFAS, is associated with an increased risk of kidney cancer. We also have a number of unique exposures in the iron range due to mining exposures. There was a focus studies on mesothelioma incidents in taconite mining that was noted in Minnesota. This was being tracked by the Cancer Registry and is something that we should also continue to focus on going forward. We also have a number of other exposures, including arsenic, which is often found in private wells and is associated with bladder and non-melanoma skin cancer. You can see here in the map on the right from the Minnesota Health Department that this tends to be an exposure that's more prevalent in rural areas where people are more likely to have private wells. Higher levels of arsenic are seen here in the map as shaded in the dark green color. And then finally, Minnesota also has a number of areas with very high radon exposure, which is the largest cause of non-smoking related lung cancer. So if we look here again on the map from the health department showing radon levels by county, we can see that along western and southern Minnesota, we have some counties with very high levels of radon exposure. So overall, these data give us some ideas of what our priorities could be in the catchment area. We have a number of demographic characteristics that are unique or notable to the Cancer Center, including the large rural population, a number of unique immigrant populations, and also an American Indian population with some large health disparities. We also have several notable cancer incidence and mortality rates compared to the United States as a whole. Non-Hodgkin lymphoma and leukemia both have higher incidence and mortality in Minnesota compared with other areas of the United States. And then we also have a number of cancer disparities that we should also evaluate, including disparities in colorectal and lung cancer in the American Indian population, colorectal cancer incidence and mortality in the rural population, and also disparities in prostate cancer mortality. If we look at environmental exposures, there are a number of areas that would be good to focus on that are unique to our catchment area. And finally, a number of differences in behavioral factors that may help explain some of these differences and may be priorities for cancer prevention and control efforts. So this is the end of the analysis of the catchment area. And I thought I would pause here and stop for questions if anyone has any. Just showed you a lot of data before I go into talking about the catchment survey, that this might be a good time to take some questions.
Just a reminder that people can type their questions into the Q&A module or raise their hand and I'll allow them to unmute. We do have a question typed in already, Dr. Poynter, if you wanted to read that one off from Dr.
Sure, yeah. So this is from Scott Dem. With regard to higher incidence for certain cancers in rural versus urban centers, is the rural population older on average than the urban population? And are the incidence statistics age adjusted? Those are both great questions. Yes, the rural population is older on average than the urban population. And I did forget to mention that all of the rates I presented are age adjusted. So just the older age itself can't explain the difference in prevalence or incidence and mortality that we see in the rural population.
That's great. And then we have a raised hand. Dr. Yee, I'm going to allow you to talk. Go ahead.
Yeah, hi, Jen, that was great. And I was about to type in this question, but it was too long. So you mentioned the difficulty in identifying Somali populations, and I'm making, or East African immigrant populations. I'm making an assumption they are being blended into the African American population. So how do you think that affects the statistics like smoking or obesity or other health habits? And do we need to, so the smoking looks sort of bad, but is it worse if we either subtract or add Somali populations and smoking habits and obesity?
Yeah, I think that is the issue, and that is they are being rolled in with the African American population, and I think the health behaviors are different in the two groups, so I think it's likely that we're kind of averaging them out and masking some of the effects. So that is the main reason we'd like to be able to separate those groups out so that we can look specifically in the East African immigrant population compared to the African American population. So it's just a little bit tricky because of the way the data are collected. Typically we'd use something like language spoken in the home to separate those out, but that information is not collected at the cancer registry. So you have to use other methods to try to figure that out.
Okay, thanks.
Any other questions? Doesn't look like it.
All right, sounds good. So next I'm going to talk about a statewide survey that was done within our catchment area. This was funded by a supplement to the Cancer Center Core Grant. And this is work that was led by Deanne Lazovich, who was a longtime cancer member and has recently retired. She was the one who led this survey with a number of co-investigators who are listed here and a large number of collaborators. And this was her work and some slides that she presented at several conferences, so I am presenting on her behalf. So you might be wondering why we'd want to do a survey in the catchment area. And really, if we're trying to understand the catchment burden and risk factors relevant to our catchment area, it's really important that we have some data, and these data really don't exist in other areas. So the National Cancer Institute does conduct a health survey. It's the Health Information and Trends Survey, or HINTS, to monitor cancer-related issues and practices within the United States. This is done every 2 to 3 years. However, these national data don't really help individual cancer centers because the data are aggregated across the entire country. We also have data from the Behavioral Risk Factor Surveillance System, which I used briefly in the previous section of my talk. But in this survey, it's really to collect all kinds of risk factors, and they don't include a lot of questions on cancer. They did have a few screening related questions and some relevant risk factors, but that's really it for cancer. So the supplement to do this survey had a number of specific aims. One was to understand the population of the catchment area, and this was done to evaluate both demographic and behavioral characteristics and look at to try to help us inform our strategic priorities. So this was accomplished through a mailed survey that was sent out to a random sample of Minnesota in residents. Another aim of this was to geocode all of the data from the addresses of the participants, and this would allow for using community level data on different characteristics that's available for the population as a whole, to look at things like demographics, socioeconomic status, and healthcare resources. And then the final goal was to collaborate with other groups who also implemented the same survey at the same time to compare and contrast for different analyses. And so the data so far have been used as part of a rural working group analysis from other cancer centers with large rural populations, and then also to look at social determinants of health and other cancer risk factors. And I believe that manuscripts are in preparation from both of these work groups. So hopefully we'll have some results from those analyses soon. So I mentioned that the main part of this survey was a mailed survey. It was conducted last year in 2019 from May to August. Households were sampled randomly, and overall 1,600 surveys were mailed, with 1,000 of them to non-metro areas and 600 within the metro area. So the survey used the Dillman method, which is a well-known method in epidemiologic survey research, which includes an initial mailing followed by a postcard, a second mailing, and a final reminder letter to try to get people to respond to the survey. We also, a $2 bill was included with each survey as an incentive to hopefully encourage people to send their survey back. And overall, over 700 surveys were returned for a 47% response rate, which is actually pretty good for a cold mailing of a survey in the current time. So the survey included 2 sections of questions from the hints, including a section on demographics and also a section on behavioral questions. And this is a copy of what the survey looked like. We also had some cancer center specific questions, which are listed here. I won't go through all of the data in detail, but just wanted to give you an idea of what was included on the survey. And then, as I mentioned, there was a goal to do geocoding, which would allow us to get community level measures. And here I'm just showing you some examples of the type of data we can link to within the community to obtain some of these data, including data from the census, area health resource files, county health rankings, and also from the state cancer registry. So this slide is just showing some overall characteristics of the study participants. So overall, which is pretty typical in survey research, we ended up with a larger female population with 60% females. We also had overrepresentation in the population over 65. This comprised about 16% of the Minnesota population and 36% of survey respondents. As we see often with surveys, the respondents tend to be more white, have higher levels of college education and higher income levels, and also slightly higher from rural areas, which is reflected by the sampling, the way the sampling was conducted. And I just want to point out one of the questions we asked was whether people had heard of the Masonic Cancer Center, and overall 40% of the survey respondents had heard of the Cancer Center. If we look at some of the behavioral related factors within the survey population overall, we see that they were slightly less likely to be smokers, very low rates of e-cigarette use, which reflects the older adult population. And then we see some data on cancer screening related variables, including colonoscopy, Pap tests, mammograms, and PSA tests. So there are a few things I wanted to point out, just since a lot of us are conducting research and may be interested in how the participants felt about participating in research. So overall, we see that more than half would be willing to participate in a treatment clinical trial or a cohort study. And if we look at specific research procedures that people would be likely to participate in, about half would be willing to give a biological sample, slightly fewer would be willing to give a stool sample. Again, about half would be likely to do an in-person or telephone interview or some sort of questionnaire, but only 19% said they would be likely to follow a special diet or take a medication, which seems to be somewhat in contrast to the 60% who'd be willing to participate in a treatment clinical trial. And if we look at the types of methods that people would respond to if they were being recruited to a study, we see that overwhelmingly people would be most likely to participate if they were invited by a healthcare provider at their clinic or a family and friends. And we see lower rates when we look at things like social media, newspaper ads, or TV announcements. Another analysis that's been done with these data is looking at the urban versus rural comparison within the survey participants. So here I'm showing you some of these demographic data. This information was presented at the Rural Health Symposium by Deanne Lazovich earlier this summer. Here we see that the rural population was likely to be older. They were less likely to have a college degree. And also had lower incomes, which is what we see overall for the state, so is not particularly surprising here. If we look at cancer risk factors, really the only notable difference that we saw between the urban and rural population was a difference in smoking prevalence, with a slightly higher percent in the rural population. None of the other differences that we saw here reached statistical significance. And here, I think she was just trying to point out the very low rates of lung cancer screening among current and former smokers, regardless of where they lived. We also see, if we look at cancer-related and healthcare experiences, we did see some differences in the rural versus urban population. The urban population was more likely to have heard of both the Masonic Cancer Center and the Minnesota Cancer Clinical Trials Network. Whereas in contrast, the rural population was much more likely to travel long distances to receive healthcare, which again is not surprising. So overall, just to summarize the Catchment survey, we see that survey respondents are likely to be older, they were more likely to be female, and more likely to be white compared with the Minnesota population overall. This is really not surprising. We see this often in surveys where people are volunteering to participate. Overall, we do see that the survey respondents are likely to participate in research, which may also be partly why they were motivated to complete the survey in the first place. We didn't really see large differences in cancer risk factors in the rural versus urban population within the study participants. And overall, we see that awareness of the Cancer Center is low overall and even lower in the rural population, suggesting we have some work to do to try to get some more awareness. And as I mentioned, there's some combined analyses with other cancer centers, which will improve power to detect differences between groups. So as I mentioned, there's a paper forthcoming on rural versus urban cancer differences, and also looking at health determinants. And I also just want to mention that these data are available for use. Dr. Lazovich has asked me to take over as PI of the survey, just to be a steward of the data. So if anyone is interested in exploring analyses with these data, they are available and to be used by other Cancer Center members. So please feel free to reach out if you're interested in using the data. So I just want to spend the last couple minutes talking about a new seminar series that we're planning to start focused on community outreach and engagement. So I mentioned earlier that NCI has new guidelines about how we need to be considering our catchment area and input from the community across all areas of cancer research, including basic science, clinical science, and population science. And we thought it would be great to be able to have a series of seminars, which were entitled Building Bridges from Research to Community, to try to get examples from both national and local researchers on how they've successfully incorporated their cancer center's catchment area into their research. So these seminars will be conducted on a monthly basis. The next seminar will be on October 20th. We have a speaker coming from Tulane Cancer Center who will be talking about survival in African American and Caucasian men from the PROCEED registry. So, so this will be a great seminar, and I'd encourage all of you to tune in for this. We'll also have other upcoming dates this calendar year on November and December 15th with titles that will be announced in the future. And I would also like to point out, if you know of someone who's doing great catchment related research, or if you're doing research yourself, we'd also be interested in some suggestions for additional individuals to fill these seminar slots. I also wanted to point out that there are a number of funding opportunities for doing catchment-related research. For the internal pilot grants that the Cancer Center will be funding, we'll be giving priority to catchment-related projects. So that is something to consider as you're putting your project together. And I also just wanted to highlight a couple of NCI funding opportunities that are catchment focused. One is relevant to our catchment area that just came out, looking at interventions to address modifiable risk factors in rural populations. This is required to be a clinical trial, but can be some kind of intervention that can try to reduce things like smoking rates or increase screening rates or other things in the rural population. And then finally, there's been an ongoing basic cancer research grant in cancer health disparities, which also would be very relevant for the catchment area. So we also are trying to reach out to different individuals who are doing work in the priority areas that we've identified from the catchment analysis. So you may be hearing from us, but if you don't and you are conducting catchment related research, we'd love to hear about it. We're trying to put together a database of things that are going on at the Cancer Center so that we can demonstrate how we're responding to our catchment area. So please feel free to reach out either to me or to Kiara Ellis if you're working in this area or if you're interested in being more involved. And with that, I'd like to thank you for your attention, and I'd be happy to take any additional questions. Yeah, so I had indicated in the introduction that we want to engage members from all of the research programs. And he also wanted to know if we've considered engaging members from the translational working groups. So yes, that would be great. We would definitely welcome engagement there. I have plans. I'll be talking to a couple of the translational working groups about the catchment in the coming months, and I'd be happy to talk to any other working groups. And I think that's a great suggestion to get members from there involved as well.
Jen, it's Doug. I just unmuted myself, I think. It was a great presentation. I just wanted to make a comment, and I think maybe a lot of members are on this call, listening, you're talking, not understanding why the NCI has mandated this. And, you know, I think I just want to put the framing argument into the idea that, one, we are a state institution. Secondly, we're supported by federal funding. And I think the NCI, and I think not just the NCI, the entire state and the legislature are interested in what are you doing for the people who you live with. And we'll call that our catchment area. And I think for those that are basic laboratory scientists listening in, I think like a lot of other things, the NCI starts within the Cancer Center, this criteria of how does your research address a particular problem for your catchment area is going to start to become a scoring criteria within everybody's basic science grants. So I don't think that it's necessarily always going to be the case, but certainly understanding what the problems are within your area, having your science address some of those problems directly or in the future, I think is going to be viewed at a higher level in terms of determining the impact for any particular grant. So I want to thank Jen. I want to thank you for actually outlining what's going on in our catchment area, because I think I hope everybody got a lot of thoughts about how their research could align with problems within our catchment area.
Yeah, I think that's a great point, and I don't necessarily think this is a new concept, because I think probably most of us went into cancer research and science to try to have an impact on the cancer burden. So, and I think there's a lot of stuff already going on within the Cancer Center that would address some of these areas. It's just a matter of all of us communicating and being on the same page about it.
Well, thank you so much for joining us today and listening to Dr. Poynter's talk. Thank you so much and have a good day.